Hi guys, it's me, Professor D, and welcome back to my YouTube channel. On this video, I'm going to be covering part 3 of bipolar disorder. So we're going to jump right in to the psychopharmacological interventions, starting with agitation. So let me make this a little bit bigger for you. Give me a second. By the way, you know you're going to watch the video. You know you're going to like it. So go ahead, please press that like button. Subscribe to the channel if you haven't done so already. All right, so let's take a look at this. Agitation. For severe agitation. Not mild, not moderate, severe. So it's really bad. This is when they pull the lithium in, okay? For severe agitation, lithium or Depakote and second generation antipsychotics such as Zyprexa or risperidone are recommended. You need to be familiar with all of these drugs because they've all been seen not only on NCLEX, but they've been seen on the ATI, Psych, and HESI. You need to know those drugs. And the most important thing that you need to pull out of this here is we pull lithium. Lithium is the big guns. We don't pull lithium out for mild or, moderate bipolar disorder or agitation. Okay, it's got to be really bad because lithium has some severe adverse effects, which we're going to talk about in a little bit. Now let's keep going. Due to concern for dependency, this is important, the use of benzodiazepines is usually short-term until mania subsides. So that's important to know. So we do give benzos for patients who are experiencing mania, but benzos have addictive properties. Patients tend to be addicted to them. So we do not give them long-term. That's one thing that's important for you to know. Another thing that's important for you to know, let me tell you how they'll question this on nursing exams. They'll tell you that, this is a patient situation. The doctors ordered a benzo. What in the patient's history would make you question this order, or at least reach out to the doctor. And it's if the patient has a history of drug abuse, they have a history of alcohol abuse, they have a history of any type of addiction, we're going to question that order because we know that when it comes to benzodiazepines, patients are at increased risk for addiction. So we don't want to give this to a patient who already has a history of addiction, whether it be substance abuse such as alcohol, cocaine, marijuana, whatever it is. So make sure you guys understand that. Let's keep going. High potency anti-anxiety benzodiazepine, your clonazepam and lorazepam are useful in the treatment of what? Acute mania. They could have just said mania. Why did they put that word acute in there? That's another reminder to let you know we're giving it for something that's happening right now, okay? And guess what? As soon as it goes away, we get rid of it. It's something that's giving short term. It's not something that we give chronically. It's not something we give as maintenance. Okay, pay attention, guys. This is how I want you to study. When you're reading the book and you see that the author is telling you the same thing, except in different ways, but when it comes down to it, they're telling you the same thing, that means it's important. That means that this is something that you most likely are going to see on your exam. And that's why they keep reflecting the same information in different ways for you to get it. This is how I want you guys to study, okay? All right, let's talk about lithium. Lithium, and you see Escalith, Elithibid. All right. Lithium, it's used for approval for both acute mania and maintenance treatment. Onset of action is usually 10 to 21 days. What does that tell us? That tells us that we should not expect to see immediate results with this medication. And guys, to be honest, that's with most CNS medications across the board, unless it's something that we're giving IV, right? Other than that, it's going to take a couple weeks that we'll expect to see a difference, especially these psych medications. Because the onset of action is so, what does that say? Slow. It's not immediate. You need to know that. Because the onset of action is so slow, it's usually supplemented in the early phases of treatment by atypical antipsychotics, anticonvulsants, or anti-anxiety medications. And in parentheses, I put bridge treatment. I think it's important for you guys to know why this is done, because then you'll remember, it makes sense. Remember, This lithium, it takes what, 10 to 21 days for it to start to become effective. But we need something to start working now. So until the patient has a therapeutic level in their bloodstream that we actually start seeing a difference, we need something working now. We're going to give them atypical antipsychotics, anticonvulsants, anti-anxiety medication, maybe a combination of them as bridge therapy to hold that patient over until the lithium starts to kick in. So that's what I mean when I say bridge therapy. The use of newer drugs has resulted in the decline of lithium use. There are, other drugs on the market now. Lithium is particularly effective in reducing the following, and you guys can take a look at this. Excuse me. You guys can take a look at this list on your own. These are all of the manifestations that lithium helps with. Therapeutic actions and therapeutic and toxic levels. Let's take a look at this. This is very important. There is a small, very narrow therapeutic range, guys. There is a small window between the therapeutic and toxic levels of lithium. That means that line is very thin, where that patient goes from something that's therapeutic, that's helping them, to something that's toxic, that's actually hurting them. Very thin line. Lithium must reach therapeutic levels to be effective. This usually takes 7 to 14 days or longer. Lithium levels should not exceed 1.5 to avoid serious toxicity. I want to show you guys something. You see how I write all over my textbooks? As a nursing student, that's what you're supposed to be doing too, okay? All right. I know some of you guys try to be cheap. Don't want to write or highlight on your book because you want to resell it. No, you want to pass and get your license. That's what you want to do. So take a look, guys. Lithium side effects and signs of lithium toxicity. So the first thing I need you to be aware of, your normal lithium level, your therapeutic level is this right here. 0.6 to 1.2. Professor D, do I have to know these numbers? Absolutely. Yes, you do. 0.6 to 1.2, that's your therapeutic level. Once that patient hits 1.5, they're now in toxic level range. You see how such a thin line that is, going from 1.2 to 1.5, very narrow therapeutic range, okay? So let's take a look, guys. When the patient's less than 1.5, this is what we want to see, less than 1.5. These are the expected side effects for this. Nausea, vomiting, diarrhea, thirst, polyuria, lethargy, sedation. You guys can look at, all of these side effects that you need to know. What are nursing interventions going to be? Symptoms often subside during treatment. You have to teach that patient that. Otherwise, they're going to want to stop taking their meds, right? Doses should be kept low. What do they mean by that? That means we are going to keep that dose at the lowest therapeutic level. So the lowest level that we give the patient that we see the positive or the expected results, okay? Kidney function and thyroid levels should be assessed before treatment and then on an annual basis. Why? We need a baseline. Let's jump to early signs of toxicity. Remember, I told you 0.6 to 1.2, that's your normal range. You hit 1.5, this is when you get into toxic. So let's look at 1.5 to 2.0. GI upset, coarse hand tremor. Why did I underline that? Because on nursing exams, that's the one they usually give you, right? For you to expect that the patient's in a lithium toxicity. Confusion, hyperirritability of muscles. Let's see if I can pronounce this. Electroencephalography. Why did I try? You guys see that word. There you go. Those changes, sedation, incoordination, nursing intervention. Medication should be what? Withheld. You're going to hold that medication and call the doctor. You see those signs and symptoms, you're going to withhold that medication, call the nurse practitioner, the healthcare provider, let them know what you're seeing so we can do what? Get blood levels drawn because you suspect lithium toxicity. Medication should be withheld, blood lithium levels measured, and dosage reevaluated. 2 to 2.5. Ataxia, you know, ataxia when they're walking like they're drunk, right? Giddiness, serious, that word right there, you see it? Blurred vision, clonic movements, etc. Take a look at that. They're going to be hospitalized. This is not something we can handle outpatient anymore. The patient will be hospitalized. The drug is stopped and excretion is hastened. What do we mean by excretion is hastened? We get it out of the patient's body as soon as possible. Excuse me. Whole bowel irrigation may be done to prevent further absorption of lithium. Lastly, severe toxicity, more than 2.5. Patient can go into convulsions, oliguria, where they're not urinating at all. Guess why they're not urinating? The kidneys have shut down on the patient and death can occur. Interventions, in addition to the interventions above, hemodialysis. Why? We need to get this lithium out of the blood ASAP. Okay, so make sure you guys know that. Lithium levels should be measured for at least 5 days after beginning lithium therapy and after any dosage change until the therapeutic level has occurred. Again, ladies and gentlemen, what is the therapeutic range? 0.6 to 1.2. Make sure you stamp that in your brain. Blood levels are determined every month. Blood should be drawn in the morning. So when we are drawing the blood, because we want to see the lithium level, we're going to do it in the morning. 10 to 12 hours after they got their last dose of lithium. For older patients, the principle of start low, go slow still applies. Why? Remember, with that older adult, kidneys not working the way they used to, which means that's not filtering out the blood the way they used to, which means it's not getting rid of those medications the way they used to. Those meds are staying in the patient's body longer and it places them at risk for toxicity. Number two, their liver's not working the way they used to, which means they're not metabolizing and breaking these drugs down the way that their body used to, which means they're keeping this medication in their system longer, which puts them at risk for toxicity. And the third reason, remember, the geriatric population, they tend to lose their sense of thirst. They don't get thirsty, so they forget to drink. And when you don't drink and you get dehydrated, everything in your body becomes what? It becomes, what's the word I'm looking for? Concentrated. Okay, so all of these factors put that elderly patient at risk for toxicity. So we always want to start at the lowest amount. Start low, go slow. Contraindications. Assessment of renal and thyroid status. Excuse me. Lithium therapies generally contraindicated patients with heart disease, brain damage, kidney disease, thyroid disease, or myasthenia gravis. Whenever possible, the lithium's not given to women who's pregnant because it may harm the fetus. I've seen that as a test question too many times to count. It's also contraindicated in mothers who are breastfeeding because it does go through the breast milk, okay? And in children younger than 12 years of age. Let's take a look at this box that has teaching for lithium. Let me see if I can make this bigger for you guys. Or you will teach a patient. It's important to continue taking the drug even after current episode subsides. Lithium is not addictive. Make sure you're monitoring your lithium levels closely. Fluid intake, this is important. Fluid intake, 1,500, 3,000 mLs per day, 6 12-ounce glasses of fluid. Why? We can't afford for this patient to get dehydrated on lithium because it's very easy for them to what? Go into a toxic level. Sodium. I talked to you about this briefly. I think it was part 1, but I'm going to repeat it again because this is very important for you to know. Look at this. Sodium intake can affect lithium levels. Guys, this is on NCLEX, it's on ATI, it's on HESI. You need to know this. High sodium intake leads to lower lithium levels, and low sodium intake leads to possibly toxic levels. So you need to be watching those sodium levels. Remember, sodium's 135 to 145. Less than 135, patient can get a toxic level of lithium, and more than 145, they may get a subtherapeutic level of lithium, okay? Teach them you should stop taking lithium if you have excessive diarrhea, vomiting, or sweating. Why? Those are signs and symptoms of lithium toxicity. But don't tell them just to stop taking your meds. Do not take, if you experience these symptoms, don't take your meds, stop taking it, but call us, let us know so we can have you come in and assess, and we're going to check your blood. Talk to your prescriber about having your thyroid, parathyroid, and renal function checked periodically. Why? Due to risk of hypothyroidism, hyperthyroidism, hyperparathyroidism, and decreased kidney function, because it can affect all of those organs. Excuse me. I skipped one over here. Let your doctor know if you're taking water pills. And when they say water pills, they're talking about diuretics. Think about it. I just told you that a patient that's taking lithium cannot afford to get dehydrated. What do diuretics do? Make you lose fluid. Diuretics put you at risk for dehydration, right? So that's important for the healthcare provider to know. Do not take any over-the-counter medications without checking with your healthcare provider. Even NSAIDs such as ibuprofen or naproxen may influence lithium levels. Take lithium with meals, because you saw those adverse effects and the side effects, they cause stomach irritation. And so taking it with meals can lessen those stomach irritations. In the first week, you may gain up to 5 pounds of water weight. Tell them that and let them know that it should, let me scroll down for you. It should taper off. But if you do not warn them about that, they'll just stop taking the med, thinking that this medication is just going to keep making them gain all this weight. Okay. If lithium is to be discontinued, the dosage will be what? Tapered. How? Gradually, to minimize the risk of relapse. All right, anticonvulsant drugs. You know what anticonvulsant drugs are. I just did a video on anticonvulsant drugs. Actually, I did a couple of videos on anticonvulsant drugs. So you guys are very familiar with this. Anticonvulsant drugs were developed to treat convulsions associated with epilepsy. True. They're commonly used to treat acute mania and bipolar maintenance. And it makes sense, because what do these anticonvulsant drugs do? Depress, slow down that CNS. That happens in epilepsy, but really also in mania as well. So it makes sense, guys. Valproate, available as Divalproex, has surpassed lithium in treating acute mania. It's important to monitor liver function and platelet count. That's important. So you need to recognize if the patient is getting this type of medication, we're going to be looking at the liver function studies. We're going to be looking at the ALT. We're going to be looking at the AST, platelets. We're going to assess that patient carefully. We're going to be looking at that platelet count, because we don't want that patient to have too many platelets, or the opposite, not enough platelets. Platelets can do what? Prevent bleeding if there's enough, but if there's not enough, what can it cause the patient to have? Clots. So we're going to be looking at that. Carbamazepine, such as your Tegatrol, Acretrol, is an alternative to lithium, valproate, or second generation antipsychotic. Liver enzymes should be monitored at least weekly for the first 8 weeks of treatment. Again, you're going to be looking at the liver function tests. In some instances, this can cause bone marrow suppression. Let's stop here for a second. Whenever you see bone marrow suppression, you should say to yourself, okay, so I'm going to be looking out for signs and symptoms of infection, because I know those WBCs are made in the bone marrow. I'm going to be looking out for anemia, because I know RBCs are made in the bone marrow. I'm going to be looking out for bleeding, because I know platelets are made in the bone marrow, okay? So it can cause bone marrow suppression and liver inflammation. By the way, guys, where do you think our clotting factors are made? In the liver. That's why patients who are alcoholic or have alcohol issues, we have to be very careful, especially if they have to go into surgery, because we don't want them bleeding out on the table. Okay. CBC should be drawn periodically. Lamictal, this is maintenance therapy medication, but look at this. Serious but rare dermatological reaction, a potentially life-threatening rash. What are they talking about? Stevens-Johnson syndrome. If you've never seen it, guys, do a quick Google search to see what it looks like, okay? This thing absolutely is potentially dangerous. Deadly, excuse me. Instruct patients to seek immediate medical attention if a rash appears, although most are likely benign. But we can't take that chance because, like I said, Stevens-Johnson syndrome is lethal. It is deadly. Second generation antipsychotics, Zyprexa or Risperdal. Side effects stem from a tendency towards weight gain that may lead to insulin resistance, diabetes, I can't speak, dyslipidemia, and cardiovascular impairment. If you can't remember all of that, please, when it comes to the second generation antipsychotics, what you need to remember the most is that insulin resistance, diabetes, and high cholesterol, because that's what, when it comes to the second generation antipsychotics, if you get a question on it, most likely that's what they expect you to know. All right, bipolar depression. So we talked about the patient that had bipolar and they were in the mania phase. They were going, happy. Nothing could bring them down, right? Now they're on the opposite end. Depression. Remember, guys, depression is anger, resentment, hostility turned towards self. Okay? Treatment of bipolar with a common antidepressant alone increases the risk of bringing on a manic episode. Let me repeat that again. Treating bipolar with a common antidepressant by itself increases that patient's risk of being in a manic episode. The risk vanishes when combining antidepressant with what? A mood stabilizer. So we don't want to give a patient that has bipolar just antidepressant, because that most likely is going to throw them into manic phase. We want to give them an antidepressant with a mood stabilizer. That's our key. Specific medications are indicated for bipolar depression. Second generation antipsychotics, and they give you examples, have been approved for treatment of bipolar disorder. They give you some other meds. Make sure you guys know those meds. What did I write here on the side? Okay, here I wrote as opposed to depress alone. I think what I was trying to say is they give the mood stabilizers as opposed to just the antidepressants by themselves. On this table, I highlighted the most important meds that you need to know in the different classes. So just take a look, make sure you know them. I suggest you make drug cards. Okay. I'm going to scroll up again for you. All right, let's talk about ECT. Remember, guys, electroconvulsive therapy, this is not our first go-to. This is after we've tried medications along with behavioral therapy, okay? Electroconvulsive therapy, ECT, is used to subdue what type of manic behavior? Severe. So again, this is not first line. Severe manic behavior, especially in patients with, look at this, guys, treatment-resistant mania in patients with rapid cycling, those who experience 4 or more episodes of illness per year. That little paragraph, those few sentences just reinforce the same thing they were saying over and over again. The fact that it said severe let us know this isn't our first go-to, right? And then Second thing they said was insulin, treatment resistant. That lets us know we've already tried treatments and it didn't work. And our third one was rapid cycling. We know it didn't work because it keeps happening over and over and over again. Guys, I promise you, if you listen to these tips that I'm giving you and you study the way I'm showing you to study, you see exactly how I'm highlighting this book and what I'm putting stars next to and the certain words that I'm paying attention to that tells me something else. If you start to study like this, you're going to see your grades go up. ECT seems to be far more effective than drug-based therapies for treatment-resistant bipolar depression. For those that nothing else has worked, we tried those meds. Depressive episodes, especially those with severe catatonic, so they're not moving at all, or treatment-resistant depression are an indication for treatment. Okay. Safety and teamwork. What did I write here? Reinforce consequences of inappropriate behavior. All right, so you're going to have frequent team meetings. Everyone needs to be on the same page because these patients will try to split the staff where, you know, when you're the nurse, they'll say, oh my gosh, you're the only one who knows what's going on around here. You're the only one that knows what to do. Whenever you're not here, this place is chaos, blah, blah, blah. They're manipulating you. They're trying to split the staff so they can get what they want. Okay. These meetings also help to minimize staff splitting, which I just explained to you, and may reduce feelings of anger, fear, and isolation. I've said to you before that it's challenging dealing with these type of patients. And so you also need to hear from other professionals that are helping these patients. So, because sometimes you'll feel like it's just you and you're all alone, and you're not. It's important to set limits. If lights out after 11 p.m., lights out after 11 p.m., no exceptions. And here I wrote decrease transference, okay? Transference of those, when it comes to these type of patients, negative emotions, okay? Seclusion and restraint. Seclusion and restraint may be warranted when documented data collected by the nursing and medical staff reflect the following points. So what are they? Substantial risk of harm to others or self is clear. The patient is unable to control their actions. Other measures have failed. This lets us know restraints and seclusion is not our first go-to. We have to try to get that patient under control, preferably self-control, help encourage them to get a grip of themselves, right? Most facilities have well-defined practices for treatment with seclusion and restraint, including a proper reporting procedure through the chain of command when a patient is to be secluded. For example, the use of seclusion and restraint is permitted only on the written order of an authorized care provider, like a physician, nurse practitioner, physician assistant, which, look at this, guys, must be reviewed and rewritten every 24 hours. And most states, that is the law, that's the rule. That restraint order, it's not like the doctor can write the order for restraints and it lasts forever. No, it's only good for 24 hours. And that same nurse practitioner, physician assistant, doctor, healthcare provider that wrote that order, they have, well, not the same one, but same license, they have to every 24 hours reassess that patient to see if the order is still necessary. Look at this. Only, what did I tell you about those words such as only, always, never? Pay attention. It's important. Only in an emergency may the charge nurse place a patient in seclusion or restraint. But under these circumstances, a written order must be obtained within a specific time, 15 to 30 minutes. So if there's an emergency, something happening where the patient's going to harm themselves or someone else, and it's an emergency, you don't have enough time, the charge nurse can make that decision to put that patient in restraints. But guess what? Within 15 to 30 minutes, you better get an order. Protocols identify specific nursing responsibilities, such as how often to observe and document the patient's behavior. Why? You have to be able to defend why that patient's still in restraints. Because let me tell you something, if there was an emergency, or let's say you had an order, that patient's in restraint, but they finally were able to get a control of themselves, You can't leave them in restraints because you're just mad at how they behave. The minute that they're no longer a harm to themselves or others, they've got control of themselves, you got to take them out those restraints. So you have to continually document on why that patient's still in restraints. And it says every 15 minutes. How often to offer a patient food and fluids? Very important. You cannot starve a patient or not allow them to use the facilities. So you offer, let's say you offer them water and they refuse. You better document that you offered them water and they refuse, because God forbid something happened to that patient. Guess who's getting thrown under the bus? You, the nurse. Okay, you document how often you offered fluids, how often you offered nutrition, whether it was taken, whether it was refused, how much was consumed, and if as much as possible, verbatim what that patient says, you document. How often the patient can use the restroom, every 1 to 2 hours. Caregivers should measure vital signs frequently, every 1 to 2 hours. Restraint and seclusions are never for punishment or for the convenience of the staff. Excuse me. Teaching for the patient with bipolar disorder. I'm not going to go over all of these. You guys can read this on your own, but I'm just going to touch up on the most important ones, okay? So the patient with bipolar disorder and their families need to know the fact that bipolar disorder is long-term. This is not like a cold. Like right now, I have a really bad cold. I got something. It's going to come and it's going to go. This is something that's long-term. It's chronic, okay? Treatment will require 1 or more mood stabilizing agents to be taken for a long time. The use of alcohol, drugs of abuse, caffeine, especially energy drinks, and over-the-counter medications can cause a relapse. They need to stay away from them. Good sleep, hygiene is critical to stability. Look at this. Frequently, the early symptoms of a manic episode comes from a lack of sleep. In some cases, mania may be averted by the use of sleep medications. Like I said, guys, you can pause to read the rest on your own and see if there's anything else. Oh, that's it, guys. So that's it for bipolar disorder. I was able to complete this in a 3-part series. I'm proud of myself. Let me know what you think about this video in the comments. Let me know what subject you'd like to see me cover. I'll add it to my list for you. Don't forget, guys, tomorrow, Sunday, 1 p.m. Eastern Standard Time, every Sunday, 1 p.m. Eastern Standard Time, I have a video published where I go over questions and I teach you how to answer them. So make sure you check that out. Don't forget, guys, I'm on TikTok, Instagram, Facebook. If you need some audio lessons, you have a test coming up, you really need some in-depth help, check out my audio lessons on my website, nexusnursinginstitute.com. Thank you for watching this video, and you'll see me on the next video.